Hi everyone, my name's Kath, I'm from Victoria and I'm the statewide facilitator for the Refugee Health Program down there. And we've got, I'm giving you just a snapshot today because there's 15 refugee health programs, regional, metro, and they've all got their unique, distinct challenges, opportunities and what's working well. So I've just kind of taken a snapshot of what's happening down there. Down south. So what's working? I've put here, we've got a settlement health coordinator positions which are fairly new. It's a 4-year pilot, it's been going for a year and a half. And our HSP provider is AIMS, and as Jan said, in South Australia, we've had a fairly good relationship with them, and whilst obviously they're being stretched thinner and thinner with the resources they've got, as a general rule across the state, we've got pretty good relationships. Where things have gone a bit sour or a bit south is where they've subcontracted. So where we've got Uniting or Diversitat, we've definitely had some real tension between the Refugee Health Program and the case managers and the way that's run. But with the settlement health coordinators, they're based in the north and northwest of Melbourne, and that's where our really high settlement numbers are, with thousands settling there. And just to give you an example there, I think the reports just come through for the last 12 months and they had 4,000 clinical care contacts, and they sit directly with AIMS. So even though they're employed by the Refugee Health Program, they sit in with AIMS and they have direct one-on-one contact with the whole HSV program, and that's really facilitated and fostered a good working relationship and certainly helped with coordination of care for clients. And they do so many things. They build capacity in the primary care sector. They really manage those complex cases, and there's a really nice relationship that's occurring with AIMS. Haplight, I think it's been mentioned. I think overall we're all saying it's been a positive for the program, and the way it works this is what's working well and also a bit of a challenge. I haven't put it in the challenge slide, but settlement health coordinators review every single HAP ID, and they're gathering data to be able to provide back to DHA as to these people should have been a critical or a potential, these people did not need to be. So that's kind of good. We're gathering the evidence to be able to provide back so that hopefully we can improve that system as well. But across the other refugee health programs, it's generally a designated refugee health nurse who's been given the HAP IDs. They're doing the pre-arrival form, sending it back to AIMS or whoever their HSP provider is. And whilst that's great, it's also putting a fairly large burden or extra burden on their workload already. So that's something we need to look at in order to manage that. We've also got the Refugee Health Fellows, and that's working well. They're specialists who work in PEDS, adult health, ID, and basically anybody can contact them for specialist support, secondary consult. They do capacity building as well amongst the primary care sector. And I didn't want to leave out our dedicated and committed workforce. I'm fairly new to my role, and one thing that's really kind of flashing in bright yellow lights to me is how amazing all you guys really, you are. And I just wanted to acknowledge there's a few people here from Victoria, Casey, Leanne, Marilyn and Akua, who've travelled up, and I think we can't underestimate what a phenomenal job everyone does, and you should all give yourself a little pat on the back for that. Challenges, one thing we're finding is in Victoria we have mostly fixed funding, and so that's being carried on for the next 3 years, which is great because we've got long-term, fairly secure funding. But what it doesn't enable us to do, or a challenge for me, is in some of our rural settings, they've doubled their intake I know in the southeast where Maryland works, they're being stretched and stretched further and further, but how do we give them, reallocate some of that funding so that they can respond to those higher numbers? Everybody's mentioned GPs in Victoria, especially in some areas. I'm just constantly aghast at the level of or lack of care and not using interpreters, having 10-minute appointments for complex clients losing out on their Centrelink payments because they can't be bothered checking the schedule properly, or they don't upload the information to AIR properly, and yeah, it's a really big problem. NDIS, we've touched on that. It should be working okay. It's not really, but I don't think what we're seeing, it's no worse for our refugee clients than it is for the rest of the population. That's what I would say. And it's definitely not available for asylum seekers, although we have had a couple of reports of 2 or 3 clients who have been able to access it, but we're a bit scared to put our hands up and ask because we're not sure that that's actually accurate. So we're not saying anything about that for now. And the other thing is the SRSS changes and have really putting an increased burden on our community health centres who have got refugee health programs. They're seeing increased homelessness, destitution, and it's been really quite terrible to see the impacts of that. And then we've got this 3-month window to get everybody reassessed. So that's placed quite a big burden on the program and trying to get all that paperwork in. Opportunities at the moment, in June we're going to be wrapping up an immunisation pilot project that was run across the metropolitan area, and some alarming data came out of that around the lack of immunisation status for refugee clients. And so we're hoping that with that robust evidence, we'll then be able to take that to the department and say, clearly we need to address this situation, give us more money to do that, or build capacity within the local councils to do it. Monash University, did have a refugee health nurse unit that stopped and now it's started again. So that started again this year, and I think there's 12 people doing that, which is great. Our big thing for Victoria is the evaluation of our program. We have many different models of care, the way it's run, the program. So we're hoping that it might happen. We were told it was, and now we're told maybe it won't. And we're sort of really looking at what do we do? Do we have a plethora of models? Do we have the hub and spoke type? Do we build capacity and have co-location of nurses within primary care settings? So we're sort of looking at all of that. We really want ongoing and expanded funding for the settlement health coordinator position, because we see that's really has added value for our program, and it'd be great to have them in all areas where there's really high settlement. And extra support for our rural and regional areas, because they, they have their own unique challenges, and sometimes I'm sure there's a couple here, they might feel that they are feeling far away from what's happening, and obviously their resources are far less and more limited than we have in the metropolitan area. So perhaps looking at a part-time rural and regional facilitator specifically for them. So yeah, that's all.